In this section, we'll be covering Adnexal pathology, infertility, and the first, second, and third trimester evaluations. We'll get into a little bit of pathology, but for the most part, we're just going to be talking about the processes of evaluation, why we do it, and what we're looking for through each of these. Starting with adnexal pathology and infertility. So for our adnexal pathology, one of the big ones is endometriosis. Um, when we're talking about endometriosis, it kind of gets confusing with myomatosis. So I just wanted to clarify that these are two different things. So myomatosis is when the endometrium is growing into the myometrium of the uterus, so into that muscle layer. Endometriosis is when the endometrium leaves the uterus. So it is ectopic endometrial tissue, meaning it can be out on an ovary, it can be hanging out in a mass-like structure in the adnexa. These are usually asymptomatic until they start having, infertility issues, but they can also have some painful periods, irregular periods, and then, of course, infertility and dyspareunia. So sonographically, these are going to be hypoechoic with not really clear margins to them. You may see a mass and you're like, oh, is that the ovary? No, I don't see any follicles on it. What could this be? It's darker. It's most likely going to be endometriosis. And I will tell you, from working in the hospitals, they will usually follow this up with an MRI just to get a better visualization of it so that they can really see where that endometrial tissue is coming from before they proceed with anything crazy, and to double check if it is endometriosis. Which leads us to endometrioma. This is also known as a chocolate cyst. This is endometriosis in the broad ligament. So remember, we have our bat wing that hangs anterior to the ovaries and drapes across the sides of the uterus. If we have endometrial tissue growing in that broad ligament, it will appear as a chocolate cyst or an endometrioma. It's the same symptoms or clinical findings as endometriosis, and we're still going to have that hypoechoic mass with a little bit of posterior enhancement. Next, we have a Krankenberg tumor. These are metastases, from another cancer. So primarily a gastric carcinoma or breast cancer, appendix cancer, intestinal cancers. They're usually just coming in with some feeling of fullness, some bloating. Other than that, they're pretty asymptomatic. And you'll see some bilateral adnexa ovarian masses. They're hypoechoic, and they still may have some through transmission, but they're not going to be super pretty. If you can see here, we've got some mets throughout here. Those are going to be our Krankenberg tumors. When we talked about ovarian cysts, we talked about cysts within the ovary. These are actually para-ovarian, meaning around or outside of the ovary. And they're going to look exactly like a regular cyst. You might have some debris inside of it if it's hemorrhaging, but it's going to be separate from the ovary. And it's going to cause pain just like a normal, not normal, but an ovarian cyst would. So just a quick review. We talked about PID or pelvic inflammatory disease back when we talked about pathologies of the uterus and fallopian tubes, but this is actually just inflammation or infection is the primary reason for these. So, STDs, if they had something going on postpartum, like leftover um, products of conception, or if they had bacterial vaginosis, it can turn into pelvic inflammatory disease where those fallopian tubes are inflamed. And you can see here we've got, I like to call it the muscle man. Anytime we have anything going on with the fallopian tubes, so you can see your uterus here, and then the muscly bicep arm coming off of it in like a tubular fashion. We got the same thing here. And then here again, we have that fallopian tube is nice and inflamed. Once we've had a history of pelvic inflammatory disease, we have something else that can kind of be a result of it, and that's the peritoneal inclusion cyst. Now, these hang out around the ovary, and really all it is just loculated fluid surrounding the ovary. They're generally painful to asymptomatic, and not only do they come from pelvic inflammatory disease, but if we had a prior surgery like a tubal ligation or something like that, we can also have this same kind of peritoneal inclusion cyst. Still sticking with our fallopian tubes, the other thing that can cause some issues would be a primary fallopian tube carcinoma. These are going to have abnormal bleeding outside of the normal menses, and they're just going to be complex masses surrounding or inside of the fallopian tube. And you can see here we have that muscle man, which means our fallopian tube has some fluid in it, and then we have this mass sitting there within the fallopian tube. So that would be concerning for a fallopian tube carcinoma. So much like when we have pelvic inflammatory disease, we can just have fluid inside of the fallopian tube, most likely from like a tubal ligation or endometriosis. Again, pelvic inflammatory disease can give us some fluid in those fallopian tubes. They may have pain or fullness in their abdomen, and we're going to see that muscle man appearance, that tubular structure filled with fluid inside of the pelvic area. Now, the next step in hydrosalpinx would be pus formation inside of those fallopian tubes. And the way we would differentiate hydrosalpinx from pyosalpinx would be debris inside of that fluid. So we're going to have our muscle man, but it's not going to be a mass, it's just going to be debris inside of it. And then the other thing is if you think about something that's pussy or infected, we're going to have some signs of infection, maybe a low-grade fever or elevated white blood cell count. And even going a step further in the infection realm, we have salpingitis, which is inflammation inside of the salpinx or the fallopian tubes. And we're going to have that fever. We're going to have leukocytosis, which is increased white blood cell, and some pain. Anytime there's infection, those three things kind of stick together: fever, white blood cells, and pain. And then the real determining factor almost for salpingitis is going to be your increased blood flow. So if I was to turn on color onto my fallopian tube and it lit up like a Christmas tree, then I'm going to be thinking some serious infection going on above and beyond hydrosalpinx. And if that infection is not treated and it is, been ongoing for a while, we can end up with something called a tubo-ovarian abscess. So just like an abscess in the rest of the body, these are loculated fluid collections that form as a result of infection. So we still have pain, we still have fever, we still have leukocytosis, but this one has almost an added element of nausea and vomiting because they're pretty sick. And when we look at this, we're still going to have that kind of increased blood flow, not to the extreme, but we're going to have some increased blood flow around it, and it's going to be a complex fluid collection. You guys can see here. So this would be a tubo-ovarian abscess. Very complex, might have some loculations in it. And for ultrasound, when you are doing a pelvic ultrasound and you see that fallopian tube and then you see the ovary and you see this very complex fluid collection, try and see if you can kind of add a little pressure. It's going to be uncomfortable for your patient, but if you're not seeing the ovary being separated from the fallopian tube, you're most likely dealing with a tubo-ovarian abscess, because they are now starting to fuse together and create almost like an adhesion there. All right, moving away from those adnexal pathologies and kind of transitioning into infertility. So anytime we have something going on with the ovaries, the uterus, or the fallopian tubes, we're likely to have some type of infertility. You know, these organs need to be functioning at their best in order to have everything go right with a pregnancy. And sometimes that just doesn't happen. So we have scientists have come up with some really fascinating ways in order to help along infertility and help women become pregnant. And one of those is the ovarian induction. And so in an ovarian induction, if you can think about, like, you know, if you've ever heard the word induction or to induce, it's to make it hurry along or to progress faster. And so if we think about the physiology of the ovaries, you know, we have that increased estrogen, which leads to increased follicle stimulating hormone, which leads to the release of luteinizing hormone, which leads to ovulation. Well, if the problem is starting there where we're just not ovulating, they can actually go in and give them a medication to increase that follicle stimulating hormone, and then use labs to kind of see when's the best time to give them an additional hormone, which is HCG. And so they'll watch their labs after getting these follicle stimulating hormones until it's the right time, and then they'll get an HCG injection, which will then cause them to ovulate. So it's a very in-depth process. These women are getting scanned quite frequently. We're doing follicle counts on them. We're watching to see the growth happen before they're injected with HCG. So if you ever work in a fertility complex, then you will do a lot of follicular counts on the ovaries. Along with that same kind of thing, when we see those, you know, eggs maturing, sometimes what we'll do is we will take out that egg and they will fertilize it in a lab and then put it back into the uterus. And that is what is happening with in vitro fertilization. Now, I want you, the next three, I really want you guys to pay attention to what we're inserting and where we're inserting it into. This will help you differentiate between the three, okay? So in vitro fertilization, we have an ova. That is an unfertilized egg. They take it out, they fertilize it in a petri dish, and then they stick it back into the endometrium, right into the center of the uterus. Okay, the next one, a gamete intrafollicular transfer. Now we're looking at an oocyte. So this is still a unfertilized egg, but the key here is that it is mixed with sperm and put into the fallopian tube. So it is not put directly into the uterus, and furthermore, it is never fertilized. So what they do is they almost kind of make, you know, like a mixed drink of egg and sperm, and then they stick it into the fallopian tube in the hopes that naturally the egg will be fertilized once it's in its home area, once it's comfortable. This is a proven method. The sperm will fertilize the egg in the fallopian tube, and then it can continue down its path, becoming, you know, that blastocyst from natural fertilization that happens in the fallopian tube. The third one is zygote fallopian transfer. Okay, so this one we're taking a zygote. So if you guys remember back from anatomy and physiology, when you have your oocyte, it is an unfertilized egg. When we're talking about a zygote, this has already been fertilized. So they took it out, they put it in a petri dish, they fertilized it, and then they put it into the fallopian tube. So a pre-fertilized egg goes into the fallopian tube. That is a zygote intrafallopian transfer. So really, for these three, just pay attention. Are we talking about an ova, oocyte, or a zygote? And then are we putting it into the endometrium or the fallopian tube? So we know how to treat infertility, but we have to do a pre-evaluation before we can decide which fertility treatment is going to best suit our patient. And this is where infertility clinics rely on ultrasound techs to be able to evaluate the uterus, the ovaries, and the endometrium. So infertility is defined as an inability to get pregnant with trying for 1 year. And so they'll come in after this year and they'll do an ultrasound, and we're checking the uterus for any congenital abnormalities, right? So that septate uterus, if they have a complete septation there, they can have that surgically repaired, which will then allow them to have children, or any other type of abnormality in the shape of the uterus. And we talked about those. Go back if you're not really quite sure, go back at the anatomy video and look over those and know those different types. Now, when we're looking at the endometrium, we're trying to figure out what is the luteal function. Is it growing? Is it not growing? How big is it currently? Is it viable for implantation at this time? And so we want the endometrium for an implantation to be greater than 11 millimeters. And this is full luteal function. It is ready to host a embryo in there. When we're seeing something that is less than 8 millimeters, this is going to be associated with a decreased function. And this might be because they don't have enough spiral arteries to build that endometrium, or they're not getting proper vascular flow to that endometrium. And so as soon as we put something in there, it's not going to be able to sustain it, and then we have an increase of pregnancy loss. For the ovaries, we're going to be checking for the presence of follicles. More specifically, we're going to look at dominant follicles, and these are between 1.5 to 2 centimeters in diameter. We are going to measure every single follicle we see that is greater than 1 centimeter. If it's less than 1 centimeter, we're not going to measure it. But keep in mind that you want to document this really well, because you are going to be following up somebody else in the future too, and so you want to make sure that you guys are measuring the right ones. So dominant follicle, optimal size 1.5 to 2 centimeters in diameter. On the flip side of infertility is fertility issues. So if you're able to get pregnant, but maybe it doesn't go into the right spot, or we're having too much follicle stimulating hormone, that's kind of where these guys fall in. So number one, ectopic pregnancy. So this could have happened naturally. This could have happened as a result of a zygote transfer into the fallopian tubes. However it happened, we have a pregnancy happening outside of the uterus. So this is a non-viable pregnancy. It is outside of the uterus. Then we have multiple gestations, and these are kind of frequent with IVF. If you ever hear of like Octomom, where she had like a ton of kids, she used IVF in order to conceive, I believe. Don't quote me on that, but maybe check it out and see for yourself. But I'm pretty sure she used IVF, and there's a whole debacle about it. But very commonly, when they fertilize eggs and stick them into the endometrium in IVF, they do multiple. I mean, they might fertilize 5 eggs and see which one sticks, because not all of those eggs are going to stick. And so they want to increase their odds. And then if multiple do stick, well, now you have multiple gestations, which is going to increase the risk during pregnancy when you have more than one baby in that uterus. And then lastly, ovarian hyperstimulation. This is when we are giving that follicle stimulating hormone, and we get all kinds of eggs that have been stimulated, but none of them are ovulating. So they're all stimulated, but none of them are releasing. And so our ovaries get massive. We have massive cysts. If you can see the picture there, that would be hyperstimulation syndrome. And this can lead to fluid buildup in the pelvic area. And the added stress on the body can even get fluid into the thoracic cavity, so that pleural effusion. So we finished up Adnexal, and we are moving into the first trimester assessment. So the first trimester is from week 1 to the end of week 12. So this would be week 1 to 12 weeks, 6 days. Okay, once we get into that third week or 13th week, we're no longer in the first trimester. So week 1 to 12 weeks, 6 days is the first trimester. We're going to go into a lot of detail about embryology and what our roles as a sonographer are during this exam. So stick with me. All right, so embryology. So embryology is the study or the science of the formation of the embryo. So this is how it's fertilized until it's implanted and it's growing in the womb. We're really just going to cover kind of the first trimester here. I really want you guys to make sure that you understand this front and back, and you have a really good understanding of the different stages of the cell and where fertilization is taking place, and all of the labs behind it. If you guys don't understand that, please go back to the ovary PowerPoint and make sure you understand all of the labs that are happening. The embryology is a hot question button for the AART and the ARDMS. So really making sure you understand what is happening at each stage is critical. There are plenty of YouTube videos if you don't understand it and this isn't enough. And then I would be more than willing to tutor any of you guys on embryology and what is happening there. And just please make sure that you understand this before you move on. So pause it when you're done with this, rewatch it, really understand it. Maybe look up some other YouTube videos if you're still not understanding it. All right, we are going to start our story of the embryo in the uterus. So we have our uterus. Just going to point out some key spots that we're going to really be paying attention to. So we have our vagina, we have the cervix, we have the endometrium, we have the body and fundus of the uterus, we have our ampulla and, cornua, and then we have our fallopian tube, we have our fimbriae, and then the ovary here, and that is where our story begins. So if you guys remember from our ovulation story back in the intro to pelvic and the physiology, estrogen is going to increase around day 14 of the menstrual cycle. And this estrogen increase causes the pituitary gland to release luteinizing hormone. And luteinizing hormone is what creates ovulation. It creates that egg to burst out of the ovary, and then once it comes out of the ovary, these fimbriae here are going to create like a movement of the natural fluid in the pelvis and kind of pull that egg into it. It is going to make its journey into the fallopian tube, and then hopefully that is where it is going to be fertilized. At the same time, we have intercourse, and the sperm makes its way into the vaginal canal, swims up through the cervix. It is now in this big open cavity, and it has to pick. Is it going to go this way through the right fallopian tube, or is it going to go into the left fallopian tube? Now remember, in our story, the egg is in the right fallopian tube. If it goes to the left fallopian tube, it goes into nothing. So it is not going to find an egg there. But if that sperm decides to go into the right and it finds that egg, it is going to touch that egg, and its head is going to fuse with the egg, and it is going to release its DNA nucleus into the egg. Just a reminder, we have 46 chromosomes in our body. 23 are housed in that ovary egg, and 23 are housed in the nucleus of the sperm. So 23 and 23 come together, they fuse, we get 46 chromosomes. This is the start of the zygote. So here we have our fertilized egg. It is 46, it's a diploid cell, and we call it a zygote at this point. Now, something crazy happens as soon as we get all of that DNA in there, and it is called cleavage. Now, cleavage is essentially the dividing, rapid perfusion or division of the cells themselves. So one cell will break in half and become two. And then in that 2-cell stage, we have 2 cells. And then they will divide again and become a 4-cell stage. So 2 times 2 is 4. And then they will divide again, and 4 times 4 is 8. One more time, we're going to do another division, and so we get 16. And at 16, we are at the morula. And so the really fun thing about the morula is that it has a hollow center. So all of those cells, instead of clumping together and staying in the center, will actually start to break out to the sides. So if I am drawing this here, we're going to do a quick little illustration. If I have my egg here and I cut it in half, I will have a hollow center with all of these little eggs kind of on the outside. And if you guys ever seen like a Nerd's cluster, right? We have the nerds on the outside of it, and then we have that gummy center. Well, the gummy center is this space in this morula, and those Nerd's clusters are those grouping of 16 cells around the outside of it. So it will divide again, and it will become 32 cells. Now those 32 cells, because we like to rename everything, is going to become the blastocyst. So we still have all of those cells on the outside, but then something else happens here where we will get one edge. If you guys notice that this side is not hollow, we will get some cells that kind of group together on one side of the cell. And so we have this outer cell mass, which is all of the ones on the outside, and then that clumping of cells that happens on one side is going to be the inner cell mass. And that's super important to remember that at the blastocyst stage, we have inner cell mass and we have outer cell mass. And then as we continue on, we are going to have those cells within this blastocyst that are going to differentiate. And what I mean by differentiate is they're going to become very specific. So they are going to decide what part of the baby they are going to grow into. And as they do that, they're going to continue to move and continue to divide. And as they continue to divide, this blastocyst will now become, instead of an inner cell mass and an outer cell mass, we will now call it the trophoblast, which is the outer cell mass. and the embryoblast, which is the inner cell mass. And remember those two terms. So we have tropho, which is out. It is not going to be a part of the baby. And then we have embryoblast, which will turn into the baby. Guys, this set happens within the first week. So we haven't even made it out of the first week of fertilization. And these cells are going to keep differentiating. They're going to implant into the uterine wall around this stage and continue to turn into the spinal cord and bone and eyes and teeth and hair and whatever else it is. So the other thing that I wanted to point out about this blastocyst, guys, is that when it implants into the endometrium, so it's rolling along 2, 4, 8, 16 cell stage, when it gets into the blastocyst stage, it's going to implant into the endometrial wall, and it is going to create something, remember this term, a trophoblastic decidual reaction. And so it will almost even kind of like melt into the wall of that endometrium, and that's what that is, okay? At that point, it is going to start releasing HCG hormone to kind of communicate with the rest of the ovaries and the endometrium, hey, there's this thing that is rapidly growing inside of you. Don't try and ovulate again. We can't accommodate extra room. We have a house guest now. Okay, and then so once that happens, we will get a positive pregnancy test, and yay, you're pregnant. So at 4 weeks, when you get that positive pregnancy test, this is that formation that you already have inside of your uterus. So we already know what is going to be our spinal canal. We already know what is going to form the brain. And we even have little limb buds that are going to kind of start coming out. So moving on, we are going to kind of take a look at what do we do when they come for their first ultrasound. So they found out they were pregnant about 4 weeks. We can already kind of see that outlining of a spine. How do we date where they are at? And that's what we're going to learn about in measurements. And in order to know where we are in our dating and to make sense of the dating with our measurements, we need to know kind of what we expect to see. So day 28, we have complete implantation. Those chorionic villi link in with the maternal tissue, and we can see that we are fully engulfed into that maternal tissue there. Once that happens, we get something called a primary stalk. So it's like the first yolk sac, you can say, okay? About 4 weeks, so before we ever see the patient, because remember, at 4 weeks, we're not going to be doing an ultrasound. That HCG is not high enough. We're not going to see anything. So about 4 weeks before they come to us, that primary yolk sac has regressed, and we get the secondary sac. Now, this secondary sac, you can see it here. It is going to form between the amnion and the chorion. Okay, and that is what we may or may not see when we come for that first ultrasound, is the chorion and the amnion. We definitely should see the amnion, and we definitely should see the yolk sac. We're not going to see something this developed in that first 6-week ultrasound, but we're definitely going to see that yolk sac, and that yolk sac is almost always the first identifiable thing next to the gestational sac that we're going to see on ultrasound that indicate signs of pregnancy. We can further break this down into weeks. So that first trimester, let's break that down. So 28 days, it's 4 weeks, we've got implantation, the alimentary canal is forming, the neural tube is beginning to form. Week 5, we get that heartbeat. So our first ultrasound, it's about 6 weeks. You should definitely be seeing a heart flutter in there. 6 weeks, we start getting internal organs beginning. Week 7, we get arm buds and the rhombencephalon. So if you're seeing the rhombencephalon on your ultrasound, you can estimate that fetus is somewhere between 6 and 7 weeks. 8 weeks, we have a stomach. That's that organgenesis. Our internal organs are present and visible now. Between 9 and 12 weeks, there's something called a bowel herniation. This is a normal process, okay? The bowel will come out and kind of herniate into the umbilical cord. And so that usually happens about 8 weeks. The only time it becomes abnormal is when it doesn't resolve at 12 weeks. So if you are past 12 weeks and you're still seeing that hernia, it's now abnormal. But prior to then, this is a totally normal function of organgenesis that needs to happen in that time frame. Now, at the end of that 12 weeks, at the end of the first trimester, we're going to see most of those organs. We're going to see brain structures. We're going to see the stomach. And then as we enter into week 13, we have a new guest. So that secondary yolk sac is going to disappear. It is going to come into the chorion, and the amnion are going to fuse together at that time, and that is when that yolk sac disappears. When that happens, we need something to take over giving nutrition to the baby. And so remember, I said that yolk sac is just a picnic basket that's along for the ride. So that picnic basket disappears as the placenta comes in and takes over. All right, let's get into protocols and measurements. The first thing that I always do when starting a OB ultrasound is I take a look at mom. And everyone is so excited to see this baby. Mom's like, can I see the baby? Can I see the baby? And sometimes you just have to explain it. Like, yes, we are going to look at the baby, but first I want to make sure that you're good. So I'm just going to take some really quick measurements, and then I will show you everything that I can as soon as I get these. And in that time, I am assessing the uterus. I'm doing the adnexa, the ovaries, just to make sure that we don't have anything else outside of there. And we're going to talk about some cases where you may have something outside of there. So it's super vital that we're taking time to assess mom as well as baby. Then we can get into the fun stuff and we can start looking at baby. We're always going to do kind of a dating measurement in the first trimester. And this is where we're going to take the mean sac diameter and the crown rump length to give us an average date of the baby. So the mean sac diameter, you can see it here. We're going to do sagittal, length, and AP, and then transverse, width, or you can do AP here as well. And it'll give us kind of just a rough estimate. In this case, this baby is measuring 9 weeks, 3 days, and that falls into our first trimester. Then we're going to do our crown rump length. So this goes from the crown of the baby's head here all the way down to the rump. So we're going to make sure that we're not including these limb buns if there are any. I like to really look at it with the limbs out to the side so that I can see the edge of that rump there. Because I see too often people getting limb buds confused. If it's like elongated, they'll measure out to here. So getting the spine is a good way to make sure that you are not going beyond that crown rump length to get an accurate measurement. The last thing we may do, depending on your facility in the first trimester, is going to be the nuchal translucency. We're going to talk about it more when we get into the second trimester. It usually happens within that 13-week span, because remember we said that the first trimester goes from week 1 all the way to 12 weeks, 6 days. Once you're into that 13 weeks, you're now into the second trimester. And this is considered 13 weeks, 6 days. So between 11 weeks and 13 weeks, 6 days is we're going to be doing that nuchal translucency. And you can even kind of see it here. So do you guys see this fluid collection here at the posterior spine? That is what we're measuring. So we'll put a caliper here and we'll put a caliper there. and measure to make sure that that is within normal limits. All right, so some things that we can expect to see when we are scanning, 6 weeks, 7 weeks, 8 weeks, whatever it may be. In the embryology or the stages of creation of an embryo, they may commonly have what's called a abdominal wall hernia, where the abdominal wall is protruding outside of the fetus's belly. We do not expect this to progress into the second trimester. So if you see it on the first trimester, you may or may not document it. We'll probably follow it up into the second trimester. The other thing is the rhombencephalon. So remember I said that all of these cells are deciding what they want to be. Some will become the brain. Well, these are the cells that are going to become the brain. The rhombencephalon will differentiate into the brain. And so when we see it on ultrasound, we see it as this anechoic space at the head. I cannot tell you how many times I have seen this picture with a little Santa hat right here. And they just put a cute little Santa hat on the baby and call it a day. But they don't realize that they have just put a Santa hat on their baby's butt, because the rhombencephalon is right here, which means this is baby's head. This is not baby's head. This is baby's butt. So head, brain, rhombencephalon. The next thing is the cardiovascular system is forming and can be seen as early as 5.5 weeks, especially if we are doing a transvaginal ultrasound. And so if you think about this baby, we have head and we have butt. We are going to see some cardiac activity somewhere in here. They have massive heads when we see them. So their head takes up about half of their body space. And so somewhere around that half mark is where you're going to find the heart, and it's going to look like a little flutter. You should be able to see it. And you're going to record it with M mode. We do not use pulse wave Doppler on a first trimester pregnancy. Ever, ever, never. Okay? And then around 6 weeks, so this guy here, he is about 6 weeks old. And we know this because we can start to see little ribs forming here and here. We have some vertebrae that we can see. And then around 7 weeks, we'll start to see some arm buds forming. So the other thing, I talked about it earlier, but it would be that gestational sac. So remember I said we'll get a fluid collection in the uterus. So here's our uterus. This anechoic space is going to be our gestational sac. And then we have our yolk sac. I like to think of the yolk sac as like a little picnic basket that the baby is going to be eating off of until the placenta is formed. And this will also help you remember that at this point we do not see a placenta, because the baby has a picnic basket that they are carrying around with them. And we should definitely see this picnic basket if the mean sac diameter is greater than 8 millimeters. And when we look at it, it itself should be less than 7 millimeters. So just keep those two measurements, they're about the same, in mind. Once that mean sac diameter gets a little bit bigger, about 16 millimeters, we should be able to see that heart fluttering, and we should be able to see an embryo. So the first thing we're going to kind of see, and I like to call it the diamond ring. It's this middle picture here. So we have our yolk sac, and then right at the top, if you think about it as the diamond sticking off the ring, we will see our embryo, and we will see a heart flutter there too as well. And then some other things we'll see is the amnion. So the amnion is the sac that forms around the baby here. And we will not really see the chorion because it's kind of out here more, and you can kind of see it a little bit there, but The amnion and the chorion are those first two bubbles that baby's going to be in. And about 16 weeks, they will fuse together. And when they do, if you notice, the yolk sac is on the outside of the amnion. When they fuse together, that yolk sac disappears, and guess what appears? Our placenta. So in the second trimester, we will be able to see a placenta, but in this first trimester, we are not really going to see that placenta. So those are the things that we will be looking at as far as our structures of our fetus in the first trimester. The other thing besides the structures that we really need to focus on is the HCG levels. So HCG levels are either a blood test or a urine test that we'll do to see that trophoblastic layer producing HCG to tell us that there is a baby in the uterus, okay? This level should double every 2 days or 48 hours up until week 7. So 6 weeks, 6 days is when it will stop doubling, and then it'll peak around week 9 or 10. Once it peaks at week 9 or 10, it will kind of plateau, and then it will start to decline up until 18 weeks. So there are two types of HCG blood tests that we're talking about here. The first one is the second international standard. Now, our limit for being able to see on ultrasound is about 500 to 1200 milli-international units per milliliter. Okay, so once our HCG reaches that level, we can with certainty see on ultrasound transvaginally. The other one is the International Reference Preparation number, and we can see with this one about 1,000 to 2,000 milli-international units per milliliter. Now, the second IS standard is approximately half the value that you're going to get when you're using the IRP. So, for example, and I have it here, if I have 1,800 milli-international units per milliliter using the second IS, I'm going to have double that when I am using the International Reference Preparation. So just note that if you're taking the test, which units they are using. If it's second IS or IRP, then you're going to expect a higher number with the IRP in the way that you can see it. And on the test, they might say, with the IRP, what would you expect to see? And with the second IS, what would you expect to see? Now, the HCG levels are also going to tell us when something's awry. So we may see that there's an increase or an abnormal decrease from the last time they had it done. And when we see that, we're going to note it. We're going to say, oh, okay, so, the last time they had it done, it was higher. This time it's lower. Now we're thinking ectopic, and embryonic pregnancy, possibly a miscarriage. But if it did more than double, say, 2 days later it was triple, we're going to start thinking a twin pregnancy. And if it's quadrupled in that 48 hours, well, now we're going to start thinking molar pregnancy, because molar pregnancy will have a markedly higher HCG than doubling in that 48 hours. So things to keep in mind when you are preparing for the exam and you have those HCG levels available. Now, I mentioned all of those, paying attention to those certain structures on mom, right? Ovaries, uterus, and adnexa, because of all of the things that can go wrong. Ectopic being a big one. So ectopic pregnancy is any pregnancy that is not happening inside the uterus. So it's somewhere, could be out in the adnexa, could be at the fimbriae, it could be still on the ovary. Very unlikely that it is still on the ovary, because if you think about it, that sperm would have had to have traveled all the way through, exited at the fimbriae, and then fertilized at the ovary. Same for this one here, right? An abdominal ectopic, not very likely that it would happen. But so keep it in mind, it can happen there though. Some other places would be in the fallopian tube, with the ampulla being the most common. And remember, the ampulla is that widening space of the fallopian tube. So that's going to be a very common place for ectopics to be found. And then we can even have them kind of here down at the cervix or into the interstitial area of the uterus. So when I talk about ectopics, I'm going to talk about signs that demonstrate an ectopic, and then using your knowledge of anatomy to find out exactly where this is at, because it's not enough to say, oh, I found an ectopic somewhere on the left side. No, you really have to divulge to the radiologist. Was it in the ovary? Was it in the fallopian tube? Is it in the uterus? So clinical findings for an ectopic are going to be a really low HCG. So if they have an abnormally low HCG for how far along they should be, we're going to be concerned. Vaginal bleeding in a pregnancy or low blood pressure are going to be some other things, especially if we have what's called a ruptured ectopic, where we had an implant and then it got too big and it ruptured the fallopian tube or whatever it may be. Sonographically, we're typically not going to see an intrauterine pregnancy. So we have a special case, and I'm going to talk about that in a minute, but typically we would see nothing in the uterus, maybe a pseudosac, which is just a gestational sac with no yolk sac, no fetus, okay? And then at the space of the ectopic, we're going to see a gestational sac, really. And inside of that, we will see possibly a yolk sac or a fetus. But the real kicker is the ring of fire that happens along with free fluid. So if there's an ectopic, we're most likely going to have this free fluid. And then if we were to throw color on this, it would look like a hula hoop of color around it. So I just said that typically we would not see a yolk sac or a fetus in the uterus or an intrauterine pregnancy during an ectopic, but here's the one-off. And remember, the tests love those one-offs. So a heterotopic pregnancy means they have a viable intrauterine pregnancy and an ectopic. So 2 eggs were released, 2 eggs were fertilized, 1 made it into the uterus, 1 did not. So this guy's out in the fallopian tube, this guy is in the uterus. When we have that, we'll have an IUP, and then we'll have that adnexal mass with a fetus in there and that ring of fire. And then just make sure that you guys aren't confusing. This one I left the differentials in because it's a very common mistake that's made. There's a complex corpus luteal cyst, which are common after ovulation, and there's an intrauterine pregnancy, and we mark this as an ectopic. So just make sure that this is truly an ectopic. You need to see a yolk sac or a fetus, and then some color. If not, just denote on your worksheet complex, mass, seen, right ovary, ring of fire, those sounding alarm verbiage that we use to signify something is wrong. All right, and then we have our corpus luteum. This does not have a yolk sac in it. This does not have a fetus in it. It secretes progesterone until the placenta is ready to kind of take over. And we see this up to 12 weeks in pregnancy. Not really do we ever have complaining about this. It's usually, we have a positive pregnancy test, and then we see the corpus luteal cyst on the side. Again, we have a ring of fire. It's scary, right? It's very much like an ectopic, except we don't have a fetus or a yolk sac inside of it. All right, next we have an embryonic pregnancy. And so this is more commonly called a blighted ovum. You may hear this more commonly. And so what happens is, if you guys think back to those cell stages, we have fertilized egg, we have 2-cell, we have 4-cell, we have morula, and then we get blastocyst, right? Well, what happens is once we get to that blastocyst and we have the outer cell mass and we have the inner cell mass that are going to differentiate into different parts, it stops. We do not have an inner blastocyst mass. It doesn't form, and so we're just left with that outer blastocyst, which, remember, if we're talking about the progression, that inner part is going to turn into an embryoblast. So there's no differentiated cells for an embryo. We just have a trophoblast. And so we're going to get the same parts that the trophoblast would be responsible to. They just might look wonky. So we're still going to get that amniotic sac, we're still going to get the gestational sac, but there will be no yolk sac and there will be no embryo, and there will be no heart tones, and we're going to see the HCG is going to kind of just stop where that blastocyst level would have been. It doesn't get any more, and our gestational sac is going to be small for the dates that we were given, so for the last menstrual period. So just key things when documenting an intrauterine pregnancy. We talked about this, but I'm just going to reiterate it for this purpose. For this blighted ovum, you must see a yolk sac and you must see a fetal pole in order to call it an intrauterine pregnancy. And then this one would be an embryonic demise. So we had the last one just didn't form at the blastocyst level. This one did. We had a fetus that started to form. Unfortunately, something happened along the process, and we're going to probably talk about those a little bit more, but something happened, no cardiac activity. We have a fetal pole. We have a fetus in there, but there's no heart rate. We may have a yolk sac. We may just have a little bit of a little dot, okay? So the other thing is we're probably going to have some bleeding from mom, and we could have what's called a Spalding sign. So if you guys come with me, we have an embryo here, right? We have the uterus on the outside. We have no gestational sac. There's no fluid surrounding this baby in there. We have some brain tissue here, and then we have some calcifications, like, bone matter, right? But it doesn't look like the head. It is very wonky. We have some overlap of the skull structures. This is a Spalding sign, and the best way I can help you remember it is when there is no amniotic fluid, there's going to be a lot of pressure, and so it will actually cause the cranium or the skull to kind of concave on itself, because there's too much pressure, and these, remember, they're not sewn together at this point. They're still very soft in order for the baby to come out of the birthing canal, and so they'll just kind of fold in on themselves. And when we see a Spalding sign, that is definitely a demise. So a complete abortion, on the other hand, is not going to be considered a demise. It is considered a complete abortion because everything was able to make its way out. So we had a pregnancy, mom came in because she's having severe bleeding, passing large blood clots. We go in to do an ultrasound. She's already had one at 6 weeks that said there was an IUP. She comes back at 9 weeks and there's nothing. This is a complete abortion. We'll see cramping, bleeding, blood clots. Our HCG levels are going to decline rapidly because there's nothing in the uterus telling it that it has a guest. And so it's going to stop producing that HCG, and then it's going to start filtering it out. And so we'll have a rapid decline of that. We won't have an IUP, and we won't have any signs of an IUP. That is a complete abortion. On the other hand, an incomplete abortion would be that fetal demise where the pregnancy did not evacuate the uterus. So we can see, maybe a crown rump length. We can see a thickened endometrium. We may see a thick yolk sac. We're going to have the same symptoms: bleeding, cramping, large blood clots. We may get instead of having a decrease in HCG with an incomplete abortion, it is going to skyrocket because it's being told that there's a house guest. We have no vacancy. We cannot support another embryo in here. We're full capacity, but in all reality, there's nothing there. So we might see an abnormal HCG, much like when we have an ectopic or something going on like that. And if you see those retained products, it's kind of important to put color on it to make sure that we're not getting an infection from that retained product. Most likely mom will have to go and have a curettage done to remove that product. Then we return to that very first week of embryology where we get our 8, our 16, and our blastocysts. Remember I said the first set of the blastocysts will be that outer cell mass and an inner cell mass. Well, it'll keep differentiating and turn into the outer trophoblast and the inner embryoblast. Well, for gestational trophoblastic disease, we have an issue with the trophoblast, that outer layer of the blastocyst. And everything inside is going to still think, oh, we're good to form. And it will start forming abnormal tissue because it did not differentiate properly. And it creates this kind of snowstorm or grape clusters within the center of the uterus. We get some increased blood flow in there. And when measured, the gestational sac is going to be very large for dates. Mom is going to be bleeding. We're going to have some hyperemesis, and if you remember, that's extreme nausea and vomiting during pregnancy. And so we're just going to document this as possible trophoblastic disease. Then we have pseudocyesis. This is not a real pregnancy. It's a fancy term for a psychological defect. Mom is convinced she's pregnant. We have a negative pregnancy test. We may not have a period. We might have nausea and vomiting and abdominal distension, but it is not a true pregnancy. It is a false pregnancy, most likely a psychological condition, and we're not going to see any signs of pregnancy in the uterus or the ovaries. Well, you'd think that once baby has gone through its millionth cleavage cycle and has all of these cells that have differentiated, that they would be in the clear. But no, we can't be that lucky because we can have something called a subchorionic hemorrhage. And so at that implantation, at that decidual reaction, sometimes we can cause hemorrhaging within the endometrial tissue. And that will keep bleeding until either 1, it stops, or 2, it gets rid of the pregnancy. And so if we see this hypoechoic complex mass laterally to the gestational sac, we need to document it and measure it, because some studies have suggested that if it is more than half the size of the gestational sac, that it'll most likely lead to a fetal demise. So we need to watch it. If it's something small like this, probably not. Something large like this, we could potentially lose the pregnancy. So we want to document that for our radiologist. Then we have the leiomyoma. We can still have these in pregnancy. Fibroids just don't disappear because we got pregnant. And we can still see them in pregnancy. So if you're scanning a patient and they are pregnant and you see a fibroid, yeah, guess what? We still have to document it. So if you do not know about the leiomyoma, please go back to the pelvic chapter and spend some time looking at it. We are moving into second trimester assessment. The second trimester runs from week 13 to week 27 in 6 days. So that is the gestational age that we are going to be working in, and we have all of our organs. Organgenesis has completed, and everything is just kind of in the growing phase now. So we're going to measure and look at everything from top to toe of the baby. I have some really good images that we can follow along with, and just see what a normal second trimester assessment would look like. All right, so getting into biometry. This is where we're going to take all of our measurements and look at all of the organs that are forming, but this is going to give us a general size of the fetus. So just a reminder, organgenesis is the period where all of the major organs are formed, and it is usually about the 3rd through the 8th week of pregnancy that they're kind of all forming, and then they start getting bigger. So when we're looking at the organs, they should all kind of already be there. We are just watching them grow at this point. So biometry, let's see. We have the biparietal diameter and the head circumference. This is going to be taken at the head, at the level of the thalami, the falx cerebri, the 3rd ventricle, and the CSP or cavum septum pellucidum. So I have here in my picture, this is kind of the area that we are going to be scanning. So we have our CSP, it's going to be in the front of the head. Then we have our 3rd ventricle, and either side of the 3rd ventricle we have our thalami, and then you may or may not see these cortical plexus coming in the posterior horn of the lateral ventricle. It's not a huge deal breaker if you see them slightly. Our big things are the CSP, the 3rd ventricle, the thalami, and then this complete falx cerebri going all the way down. And the falx cerebri is this bright echogenic line just above my cursor that goes from the front of the head to the back of the head, separating the hemispheres of the brain. So we are going to take the biparietal diameter at the outer to the inner on either sides of the head, and then the head circumference is going to go on the outside only to include the bone. If we have any tissue here that we can see, we are not going to include it. So BPD is outer to inner, and then the head circumference is including the brain or the skull, but not the tissue on the outside. Then we have our abdominal circumference. So this is at the level of the stomach and the portal vein. So when we are looking at this, some landmarks you guys need to know so that you know how is baby lying. We have our spine, then we have our stomach to the left of the spine, and then we have our aorta and IVC anterior to the spine, and that umbilical vein is going to be coming up and turning into the portal vein here. So this is the landmarks that we want for that abdominal circumference. And now, unlike the skull, we are going to include any tissue. So if we have a nice chunky baby, we're going to include all of that into our abdominal circumference. And then we have our femur length. So the femur is that big bone in the upper thigh, and we measure this as a tool of dating and size measurements. When we do this, we have the epiphysis, get that one out, epiphysis on either side. So it's this protruding pointy part at the top. So this would be the proximal, this would be the distal. When we are measuring the femur length, we do not include those. We stop right here. So we're going to measure from here to here, not to include that epiphysis, okay? Then we are also going to check some labs to kind of give us a better dating time frame, okay? So AFP, we check this. This is a hormone that's going to be produced by the fetus themselves. And when we're checking AFP, it is almost a screening tool for abnormalities. So, you know, if we have multiple gestations, it's going to be elevated. If we have some kind of like spinal cord defect or abdominal wall defect, it's going to be elevated. Renal anomalies and an underestimated fetal age is also going to be elevated. But we have the flip side. When it's decreased, we could have trisomies or trophoblastic disease or something like that. So it needs to be kind of in this sweet spot. If it's elevated, it has a list of things. If it's decreased, it has a list of things. Know them, okay? And then know that AFP is produced by the fetus. Then we have our quad screen. And so even by its name, you can kind of tell there's 4 things in the quad screen. It's going to be AFP, unconjugated estradiol, HCG, and inhibin A. You don't need to know a lot about these. Obviously, HCG is going to be related to the pregnancy, and AFP is going to be related to the pregnancy. But if you see something that has a quad screen, also add estradiol and inhibin A into that. All right, so let's get into our anatomic survey. We are still going to check on mom. It does not say that in here, but please make sure that you are looking at the adnexa, the ovaries, and the uterus, as well as these additional structures that we're going to mention. First one is the cervical os, the position, and the placenta. So when we are looking at the fetal position, we need to know, are we cephalic? Are we breech? Are we incomplete or complete breech? Are we frank breech? What's going on there? If you guys don't know those, they are in your book, and it really goes into detail about, you know, feet first versus butt first versus head first. So, and then transverse, are we getting an arm out of the cervix first, right? And then we want to demonstrate the internal os and the external os and the length of the cervix itself. If we have some shortening or some funneling happening, we need to know about that. And then the placenta. Is it up high in the fundus? Is it down really low to that internal os? If it is, we need to document how far away from the internal os it is, and then exactly where it's at in the uterus if it's not. When we are looking at the cranium or the head, there are several things that we're going to be looking at. Here's the list here, but I want to go through. They're so important that we are going to take a look at what level we are going to look at all of them as well. So just bear with me as we go through all of these. But here's the slide that kind of puts them all together. So, little bit of knowledge on the brain. So there are 2 hemispheres to every brain, and those 2 hemispheres are connected by the corpus callosum. We have sulci and gyri, which are the indentations and the bumping out of the brain. And then we have the temporal lobe, we have the frontal lobe, we have the parietal lobe, and then we have the occipital lobe. And then we have the cerebellum. So the cerebellum kind of hangs off this back spot here, and looks like it's a bunch of cauliflower or something just hanging off there. Then we have our ventricles. And we're going to kind of need to know a lot of these ventricles. So just going through them, we have the anterior horn of the lateral ventricle, the posterior horn of the lateral ventricle. We have the third ventricle, the fourth ventricle, and then we have the cisterna magna, and this one really highlights it a lot better. So the cisterna magna, if you have your cerebellum right here, it's going to hang out in that posterior aspect of it, and we do need to check this. So, and then the other thing I wanted to point out just really quickly is the CSP. So it's in that frontal horn of, or near the frontal horn of the lateral ventricle. So keep that in mind. If you guys want to go through and look at these again and kind of look at everything, feel free to do so. So when we are looking at these CSP, choroid plexus, bulks, and thalami, and those lateral ventricles, does this picture look familiar? It should, because this is where you are taking your head circumference, right? We have our CSP, we have our third ventricle, we have our thalami. This is where we're going to take our head circumference. We may also see those posterior horn of the lateral ventricle and the choroid plexus, which appear as an echogenic material in that anechoic structure. And the choroid plexus are responsible for production of cerebral spinal fluid. So they kind of all go together, and they're all kind of in the same image. If you take this image in the right spot, you can get all of this anatomy plus your BPD and your head circumference. So keep that in mind. It's not 800 million images. You can really get it in one image. Then we go into our cisterna magna and our cerebellum. They're buddies too. When I pointed it out, remember it hung out on that posterior aspect of the cerebellum. So that's where we're going to be looking. And if you see here, we have our circus peanut, I like to call it here, your cerebellum. And then posterior to that, you have this fluid collection. And this fluid collection is the cisterna magna. So circus peanut in the back, and then fluid, cisterna magna, and cerebellum. And then nuchal translucency. If you guys remember way back when we first started this, I said that it kind of hangs out in the first trimester, end of the first trimester, beginning of the second trimester. So the nuchal translucency is a very specific test, and you actually have to kind of have a certification to do it. So you have to send in several images and get a special certification in order to do an NT scan. And it's because it holds a lot of weight. So this is checking, this is like a marker for trisomies and chromosomal abnormalities. So they really want to make sure that we're not over measuring it or making some crazy thing up. You really have to know what you're doing with it. So it is a fluid collection that hangs off the posterior aspect of the baby. So we have our spine, and then we have this NT or nuchal translucency. And we take our measurement right here at the neckline. And we have to do it between 11 weeks and 13 weeks, 6 days in order for it to be counted. So when you're doing that, if you see like a lot of fluid here, this is probably abnormal. It should look more something like this, not something like this. Moving into the thorax evaluation. Again, these all hang together. I'm going to break the heart down because it doesn't hang together and you really have to do a dedicated scan for the heart. But the lungs and the diaphragm hang out together. So we know that superiorly the lungs sit above the diaphragm. And the diaphragm is that really big, thick muscle that separates the thoracic from the abdominal cavity. So below the diaphragm, we're going to see that liver. And so not even knowing anything else other than that, you can tell that we have a liver here, right? We have lung here. This is going to be the superior portion of the baby, and then this separation between the two of them that drapes down is going to be our diaphragm. So we have, in one picture, we have our lungs and we have our diaphragm. Before we get into observing the heart on ultrasound, I really want to talk about the flow, because you can't understand the anatomy of the heart without understanding which way the blood is going. So when we're talking about fetal circulation, we are talking about how the baby is getting blood, how it's filtering through their system, and then how it's returning to mom to be reoxygenated. And so we're going to start, where does the blood come from? Well, it comes from the placenta. So the placenta is the network between mom and baby. And so all blood flow starts in the placenta. And I have this chart here, guys. I want you guys to kind of follow through with me. And then we'll relate it over to this stuff. So it comes in through the umbilical vein, into the left portal vein, then it's shunted through the ductus venosum, and then into the IVC, and then right atrium. And at the right atrium, it can take two different paths. So it can either go to the right ventricle, or it can go through the foramen ovale, which is an opening between the right and left side of the heart, into the left atrium. If it takes this foramen ovale right route, it's going to go into the left atrium, then to the left ventricle, and then into the aorta. Eventually, it'll go up the ascending aorta, the arch of the aorta, into the descending or abdominal aorta. We're going to stop there. We're going to go back this other way. If we go from right atrium to right ventricle, a portion of it goes into the pulmonary artery, and then it is either going to get shunted from ductus arterius, or it's going to go into the lungs. So let's follow the lungs path first, and then we'll circle back. So lungs, pulmonary vein, left atrium, left ventricle, and aorta. Notice that once it gets into the left atrium, it follows the same route as if it were to go through foramen ovale. If it gets shunted through ductus arteriosus, it's going to go straight into the aorta. There is no left atrium, left ventricle portion to that. It always ends up into the abdominal aorta, then to the common iliac artery, into the internal iliac artery or the hypogastric artery, into the umbilical artery, and then back to the placenta to be recirculated. So let's look at it in this model here. We're going to break it down in a visual sense now, looking at it going through the organs. So we have placenta, umbilical vein, up through the left portal vein. Once it gets to the left portal vein, there's a shunt here that closes at birth, and this is ductus venosum. And it'll go into the IVC, where it will come into the right atrium of the heart. Once we're in the right atrium, so this is our IVC, here's our right atrium, right ventricle, left atrium, left ventricle. So once we're into this right ventricle, or right atrium, we can either go down into the right ventricle, or we can go through foramen ovale, this opening here. And again, if we go through foramen ovale, we're going to go left atrium, left ventricle, up through the aorta, and down into the abdominal aorta. If we go into the right ventricle, we can either go into the pulmonary artery, ductus arterius, to the aorta, or we can go pulmonary vein, left atrium, coming in here, left ventricle, up through the aorta. Either way, ending up the aortic arch, into the abdominal aorta, down into the iliac, going into the internal iliac, and then the umbilical vein, which you can see coming back up here, connecting into the placenta. If you guys are not familiar with this blood flow, I really suggest that you take time to go over this. There are a couple things that we need to know about this blood flow, that there are portions that are going to go into one section or the other. So about 60%, or 50 to 60% is going to go through this foramen ovale. The rest of it, about half to 40%, is going to go through the right ventricle and take this route here. So 60% is going to take this route. The other remaining percent is going to take this route here. Once we get into that right ventricle, the amount that goes to ductus arteriosus versus the lungs is not something you guys are going to need to know a percent. The big percent you need to know is half of it is going to take this route, the other half is going to take this route over here. Another thing before we dive into our images, I'm going to just pull up this image here for you guys to look at. So if you notice the way the heart is sitting here, the apex of the heart, this pointy part here, is sitting slightly to the left and anterior compared to this back part. So when we're going up through that left ventricle into the aorta, we are going anterior to posterior. And so our camera is going to stay along that route, going at an angle. Please notice that it is not straight across, it is on a slant. Okay, now let's go ahead and take a look at the associated images that we're going to get with it. Now the heart. It's a beast all of its own, but I kind of just wanted to, we're not going to talk about all of these images. If you want to do OB specific, feel free to kind of look at these landmarks, look at a lot of ultrasound, but I want to kind of talk to you about this cutout. Now, just because this baby isn't sitting inside of a mother, at some point it was. And so I want you to picture a baby doll that looks like this inside while you're scanning. So this lower blue here is corresponding to these. This mid-range peach color is responding to all of these images, and then this green is responding to these. And so if we are starting at the top and we are working our way down, we're going to hit that subclavian. Boom. We are going to hit our heart here, boom, and then we're going to hit the abdominal vasculature down here, boom. So portal, ductus venosus, hepatic veins, left ventricle outflow tract, right ventricle outflow tract, all of those are going to happen in here, and that's where we're going to be hanging out. So the heart has 4 chambers, and we see that in a pediatric patient. But I'm going to kind of just go over how are we scanning this. So if we are in a true transverse view on baby, we are never going to see the heart, because the 4 chambers at least, because it sits slanted, and then the ventricles are on either side. So you're not really going to see it. So you almost have to go oblique in order to cut through the 4 ventricle heart. If you find a ventricle or one ventricle or a part of the heart, just know that turning and twisting your probe will elongate that heart, and you'll be able to see the apex and the 4 chambers. So you have your apex and the 4 chambers. You have right ventricle, right atrium, left ventricle. And knowing all of those will really help how that baby is lying in there in order for you to get this beautiful 4-chamber heart. And then the next one is the left ventricle outflow tract. And if you are thinking about the anatomy of the heart in a pediatric patient, we know that the left ventricle will flow out into the aorta. And I've got a picture here. So we have left ventricle opens up to the aorta, and then it comes down to the descending aorta and through the rest of the body. So cutting this image, we're going to see our left ventricle, and then we are going to see the aorta coming out of it and long. If I want to see that, I am not going to cut it like this, right? I'm not going to cut it in that kind of true transverse. Instead, let me just go ahead and erase this line here. I am going to cut it to get that aorta in its long axis. See, we have it here. So if I'm cutting the left ventricle in a transverse form, I'm going to tilt my probe so that I'm cutting that aorta in a long view and then have a chunk of left ventricle here. Okay, so just twisting and maneuvering your camera in order to get that view. Then we have our right ventricle outflow tract. And in a fetus, this is going to feed into the pulmonary artery. So we have our right ventricle here, and our right ventricle outflows into the pulmonary artery. And so in our image, we are going to see the pulmonary trunk and the ductus venosus, and we're going to see our aorta, and we're going to see our IVC, and then we're going to see our right pulmonary artery. So that is what we are seeing here and here. But the one thing that I want to point out that we're missing in this image is our right ventricle. We want to include that right ventricle along with the right pulmonary artery, along with the main pulmonary artery and the aorta and the right atrium. So this is kind of the image that you are going to see. And how do we cut that? We are going to cut it so that we are getting this pulmonary artery in the long axis. So we're going to start here, and we are going to, let's go ahead and draw it out so we can see it remaining. We're going to cut it down like this, and we have, that wasn't very straight, but we have a bit of the right ventricle in there. We have a bit of the right atrium. We have a bit of the aorta, and we have the pulmonary artery in its long axis. And that will allow us to see as it comes up, we're going to get our right pulmonary artery, and then we're going to get our ductus going that way. So here I have our baby. Just take a look here. You know, we were looking at these like this, but in reality, we're going to be kind of cutting it like this to see everything, or maybe even cutting it this way to make sure that we're seeing what we need to see. They're not just straight across transverse cuts. All right, so moving away from the heart and the thoracic area, we're going to move down into the abdomen. Now this is very similar to an adult, right? We all have a bladder, we all have bowel, we all have a gallbladder, we all have kidneys. We want to see them, we want to see a liver, we want to see a stomach, and we want to see the umbilical cord insertion into the abdomen. This is the tricky one. So you are going to go down until you see that umbilical cord coming out, and you're going to image it there, and then you're going to image the cord itself, and then you're going to image it at the placenta insertion. For MSK evaluation, we're going to be taking a look at the bone structure as well as those soft tissue areas that are high predictors of abnormalities. In the next slide, I'm going to show you guys a lot of different pictures, and we'll go through it a little bit more in detail, especially with these more minute findings. So we're going to look at the facial structures, extremities, ribs, and the spine. So In this first image I have here, you can see this would be considered your profile. So baby's face is up, we can see the skull wrapping around, and we can see this nasal bone. This nasal bone needs to be in this image, okay, because we'll actually measure this nasal bone. If you ever work in like an MFM site, this nasal bone will get measured. It's also going to show us the maxilla here, those bones inside of the mouth, as well as the lips and the chin. So this is the profile, that is what you want to get. Then we're going to come from a coronal approach, looking up into the baby's nose area, and we're still going to see this chin, but we're going to see these lips here. We want to make sure there's no break in the lip going up into this space called the piltrum, and then we have our nose and our two nostrils here and here. This image is required by most MFM sites, so knowing that you're coming up from an underneath view of their lips, kind of a coronal view there. Then we'll look at extremities. Now around 11 weeks, we start to get what's called ossification, which means these bones are going to be brighter. They're not going to be shadowing yet like we would expect in an adult bone, but they're going to appear brighter so that we can see them. They've ossified. And we're going to mark out every limb, including, both legs labeled right and left, both arms labeled right and left, and then 5 fingers. We need to make sure that we have 5 fingers on each hand, 5 toes on each foot. You're going to do a side profile of the foot as well to make sure that they don't have any clubbing of their feet. The ribs, we don't need to count ribs. We just want to show that they're covering about 1/3 of the chest. So if I were to cut this chest in half, it would be above that half line there, and we would see the ribs in a transverse view covering about 1/3 of the abdomen. And then on a side view, just seeing how pretty they are looked out, branched out, I mean. The spine, we generally image one longitudinal view from the cervical spine all the way down to the sacrum, just to show that the skin surface isn't broken here. And then we do a more detailed in transverse from the cervical spine all the way down to that sacrum. The umbilical cord is what connects the baby's feeding system into the mother's blood supply. So this inserts at the baby's abdomen where we get our belly button from, and then connects into the placenta. And when we are doing a second trimester ultrasound, we need to show both of those insertions. One at the fetal abdomen here, and then one into the placenta. So we have our placenta here, and that cord is coming into it. The other thing that we want to show is this blue-red twisting pattern of the cord with color flow, and then at the bladder showing that we have the umbilical vein wrapping around the bladder. You can also do a transverse view, and we're kind of getting a little bit of it here, not pretty like we would want it, but showing that 3 vessel cord. So you should have your cord with 3 anechoic circles inside of it, and we would put color on that just to demonstrate that we have 3 vessels. For AFI, we want it to be between 6 and 24 centimeters in all 4 quadrants. So we're going to do a right upper quadrant, a right lower quadrant, a left upper quadrant, and a left lower quadrant. The main thing that we have to remember when we're doing AFI checks is we do not want to include any baby parts. So this includes legs, belly, head, umbilical cord. If that is in any of your AFI measurements, it will give you an inaccurate measurement. So we are staying straight up and down on that measurement here. And we're going to measure all 4 quadrants, not to include any limbs. I also just want to point this out. So when I was talking about the 3-vessel cord, you can actually see there's your 3-vessel cord right there. So if you're kind of wondering what it looked like. This brings us to the 3rd trimester. So the 3rd trimester is 28 weeks all the way to 40 weeks. And then the mother and baby are considered full term once the pregnancy reaches 39 weeks. So anything before 39 weeks is premature. Anything after 39 weeks is a full term. Even if they're 40 weeks, 6 days, it's still considered full term. So that is what we're going to be looking at here. I just want to start with a couple definitions. I included the list of indications for a 3rd trimester ultrasound because these are good questions for ARDMS and ART for OB. Why are we doing this? We need to have some kind of indication going into the exam. Maternal bleeding or bleeding during pregnancy, vaginal bleeding during pregnancy, those are going to be indications for all 3. Abdominal pain, lower pelvic pain during pregnancy, indication for all 3. But these ones are going to be pretty set to the 3rd trimester. So fetal well-being, checking on the baby. We would do a BPP or some form of exam for that specific. Amniotic fluid volume, when we do our AFI check, that's what we're looking for, is that amniotic fluid volume. Presentation, we're going to talk about how to determine fetal lie so that you can get that presentation. Late prenatal care, you may see a patient who's in week 33 of their pregnancy and they have not seen an OB. So you're probably going to be doing an abdomen complete on that patient. Placental location, if they're close to delivery, they prior had placenta previa and they want us to check it out, or they're just, checking the overall health grading of the placenta, that would be one that we would do. Fetal growth, we would do 32 weeks, we're going to do the femoral, and then 35 weeks we might do the tibia. These are going to be checking to make sure that everything is growing on target for where it should be, and will identify some chromosomal abnormalities or syndromes like dwarfism later in the pregnancy. And then the interval growth needs to be separated by a minimum of 7 days. We're not going to do it every day for 2 weeks. It's going to be 2 times in a 2-week period. 7 days, do it. 7 days, do it again. In our 2nd trimester evaluation, we talked about the head circumference and the abdominal circumference and giving a estimated fetal weight and an estimated fetal age off of that. So when we have a discrepancy between the head size and the abdominal size, or both are measuring small, this is considered intrauterine growth restriction, or IUGR for short. And when there is what we call a asymmetric, meaning that the head is fine but the abdomen is small, we can almost always assume that it's going to be from placental insufficiency, the mother having hypertension, or some form of drug and alcohol use in pregnancy. The other thing that we would check is the systolic and diastolic, or S/D ratio. And this is found in the umbilical artery. So we'll actually pulse wave the umbilical artery, and we'll take the systolic measurement divided by the diastolic measurement to see how much blood is coming from the placenta into the fetal circulation. And if that measurement is less than 3 after 30 weeks, then we're really considering placental insufficiency, IUGR. Now, symmetric IUGR is when both the head and the abdomen circumference are small. So decreased size symmetrically, and we're going to have some oligohydramnios, which means we're going to have uh, small amounts of fluid surrounding that baby. And we know that because of our amniotic fluid index, or that AFI. If it's less than 5, or we don't have a deepest vertical pocket of at least 2 centimeters, that would qualify as oligohydramnios, or too little fluid in the gestational sac. On the flip side, we can have macrosomia, which is where the baby is measuring large all over. So we have an increased head size and we have an increased abdominal size. And we're also going to see a lot of fluid, so polyhydramnios, too much fluid surrounding the baby. Another thing that we can see with macrosomia is the placenta appears large or is enlarged, and that would be considered placentamegaly. If we have a mother who is advanced in maternal age, or has some obesity or diabetes, or has had multiple children, we would be more likely to see a macrosomia. We're going to take a little bit of time on fetal position or fetal lie, just so that you can understand as you're scanning how that baby is lying in there. This is important for both delivery. If that baby is not head down, we might have a difficult delivery, but also some pathologies we can find based on how the baby is lying. So we're going to take a lot of time understanding the anatomy in the fetal lie and how that baby is positioned in there. So we can have cephalic, and cephalic is head down, head is closest to the cervix. We are not concerned about anything. That baby is in there exactly how they should be. Then we have transverse, and so in transverse, the baby is going to be perpendicular to the lie of the mother. And what I mean in that is, if we have our belly here, and we have this line, this would be our transverse. So baby's head would be either here or here, and then feet would be on the other side. We are nowhere near the cervix. In this case, we want to make sure that that placenta is not, right across the cervix. We want to make sure that it's high up. In oblique, it's going to be at an angle like this, where it's not straight up and down, and it's not transverse. It's instead at a 45-degree angle. So again, we need to know, where is baby's head? Is baby's head at the inferior margin or the superior margin? And then we have breech. Breech is when the baby's buttocks is closest to the cervix. In this case, we have 3 different types of breech, and we need to denote which one they are because each one kind of poses its own risk. So for frank breech, we're going to have that buttocks near the cervix, and our legs are going to be high extended up by baby's face. So if you're seeing feet by the face and that butt is down by the cervix, you have what's called frank breech. In complete breech, the baby's knees are going to be bent and the feet are going to be down by the cervix as well as the buttocks. So butt and feet, that's completely breech. The next one is an incomplete breech, or a footling breech. In this case, we have neither the butt nor the head by the cervix. Instead, baby's foot is going to be down by the cervix. This is the part that is going to present first. It's going to be the first part to go through the birthing canal, And this one poses the largest risk because if we have a cord floating around here and that cord makes its way out with the foot, we can have a cord prolapse where the cord comes out of the cervix before baby. This can cause pinching of the cord and some hypoxia to the baby. If that cord is smushed, there's no blood going to it. If there's no blood going to it, they're not getting oxygen-rich blood from mom, and we can have a hypoxic incident. The other part is, okay, so we know baby's head down or head up. What does that mean for the rest of the fetal line? How do we tell whether this is a right arm or a left arm or a right foot or a left foot? Because we do need to denote all of those in our complete anatomy scan of the fetus. So that brings us here. There are 3 major ways that I think that you can use. So I'm going to explain all 3 of them, and I'm going to let you figure out which one works best for you. So play the baby. You can physically picture yourself head up, face down, face up, lying inside of a ball and figure out which side is your left and right. Some people really struggle with this because we can't just lay down during an exam, right? We need an easier way to be able to tell what part is up or down without actually leaning forward or laying back. So the next way is the heart and the stomach. Both of these lean towards the left side. And so here I have my heart. If you think about how the heart lies in the abdomen, the apex of the heart points more to the left. So we have our spine, we have our aorta, and we have our heart pointing towards the left. This is baby's left side, which means baby's right side is closer to our camera. So in this case, our baby is head down with the right side being anterior. Now, that would be maternal right, okay? Thinking about how mom is lying here. This is mom's right side, this is mom's left side. So this baby is cephalic, maternal right. In the next case, we're going to find our structures again, right? We're going to find that spine, we're going to see the aorta, we're going to see the heart, apex of the heart pointing to the left, which means that baby's left side is closer to our camera and right side is more posterior. So this baby is head down, maternal left. In the next one, we're going to talk about stomach now. Okay, so we know the stomach stays on the left side. So we have spine and we have stomach. And when we are looking at our stomach, it is on the left here. That means that baby's left arm is closer to our camera and baby's right side is further away. So if baby is spine and on the left, then this baby is going to be breech, head is going to be up, and facing maternal right. The next one, same thing. Our baby is spine is here, our stomach is here. That means our baby is breech. Our butt is at the bottom, our head is at the top, and this baby is pointing maternal left. If that doesn't make sense to you, it's fine. I have another one. Some people like the heart better because it never fails. You know, you have your spine, you have your heart. Heart is pointing towards the left. That means this is baby's left, this is baby's right. The other one is the thumb method. So if you look at your hand, we're going to use your right hand, okay? Don't use your left hand, use your right hand so that you can follow along here with me. So if you have your right hand and you clench your fingers down, you can think of your thumb as the stomach or the heart. It's going to be towards the left. And then you can think of the top of your knuckles as baby's head. So baby's head, this is baby's stomach, and you can then flip baby around however you want. The other thing is the back of your hand is going to be baby's back, and the creases in your hand, if you can see your nails, that's baby's face. I like to think of it as backs are flat, so the flat side of your hand will be baby's back, and faces have so much detail. Do you see all this detail we're getting there in our hand? You can use that to remember that this is the front side of the baby, this is the back side of the baby. And you can turn that any which way you want. So you can, pretend that baby is breech. So these top two here, baby is head up. That means butt is near the cervix. So these babies are breech, and these babies are cephalic or vertex. So these babies are head down, head is near the cervix. And you can play with that. And just practice, try and quiz yourself. Come up with something random out of a hat and try and create it. Moving away from presentation or fetal lie, we're going to move into fluid assessment. So the fluid is the amniotic fluid that surrounds the fetus. And this is usually produced by the kidneys, the lungs, the umbilical cord, and the amniotic membrane. When we're talking about a normal amount of fluid, we need to keep in mind that it is going to vary periodically throughout the pregnancy. So in the first trimester, we get mostly fluid and little baby. In the second trimester, it looks like that fluid is still perfectly surrounding baby. But once we get into the late second, early third trimester, or the third trimester, it's only going to appear in little pockets. So we're not going to have mostly fluid little baby. We're going to have mostly baby with little pockets of fluid. So early on first trimester, our amniotic membrane is going to be producing that fluid. As the placenta forms, we're getting change of blood flow, and that fetus is going to start having a metabolic process. And so the fetus and the placenta will start producing the AFI. After 16 weeks, the kidneys and the lungs are going to come in and really get to producing that as the baby urinates and then breathes it in through the lungs and then urinates it back out from production of the kidneys. When we want a change of that fluid, the baby will take that fluid and send it out through the umbilical cord, or it will be processed in the GI tract. Again, the placenta, because it's going through the umbilical cord, the placenta is going to be doing a lot of that, and the lungs still are going to be removing some of that fluid. The AFI, or I'm sorry, not the AFI, the amniotic fluid itself acts as like a pillowy cushion for baby. So if mom has a toddler and toddler comes up and pushes on her belly really hard, well, it's not going to really hurt baby. If she's getting punched, that's another thing. But if we just get a little tap, that's okay. Baby is in a very cushiony fluid that is going to protect it from any injury. It's going to allow that baby to move and get their heart rate up and get that heart working so that it is ready for the real world. Temperature regulation is a big function of the amniotic fluid. If baby gets hot or cold or whatever it may be, you have to think there's a lot of cells that are growing and maturing and becoming something. If we're too hot, those cells could die. And so that fluid kind of acts as an incubator, making sure that it's not too hot. It's self-AC and heat system, if you will. And then the amniotic fluid will also help mature those lungs. When we're doing a BPP, we actually look at the fetus breathing, and there's no air in there. So there's nothing for that baby to be breathing in other than amniotic fluid, which will give practice for the lungs to grow and mature and prepare baby for the outside world where there is air. So we really want to make sure that they have the appropriate amount of fluid in order to thrive. And, it's a huge signifier to us when we're doing a BPP, if they're failing their BPP, that they could be having some hypoxia. And so part of that BPP is the amniotic fluid volume or amniotic fluid index. And so we check that. So for the AFI, there's a couple things that we need to keep in mind. One is that we have to stay perpendicular to the fluid. And we have to measure perpendicular to the fluid. So it needs to be straight up and down, anterior to posterior measurements, and keeping your camera straight up and down. We do not angle through fluid because this could give a false numerical value for what the fluid really is. And then there's a couple different ways that we can measure the fluid. Also, we do not want cord or limbs in any AFI measurement. If there's cord and limbs, we do not measure them. Remember I said in that third trimester we're going to get little pockets. If there's a limb there, you measure up to, but not including the limb. So back to the ways we measure it. We can either do a 4 quadrants that are added together. This is going to be our amniotic fluid index. We can do a single deepest pocket. So this will be a vertical pocket that we measure anterior to posterior. And then we can use if an AFI was not ordered, but we're scanning and we're going, wow, that doesn't seem like there's a whole lot of fluid there. That would be a subjective assessment because we can't really tell that there's not a lot there. We actually have to put some calipers to see that. So that would be your subjective assessment. And then once you measure it and see that there's not a lot of fluid, that would be that single deepest pocket objective or amniotic fluid index objective measurement. And we measure this because there is such a thing as too much fluid or too little fluid. And we have very good names for them, okay? We have oligohydramnios, which means too little fluid. This means that in any of the 4 quadrant that we added together, if it is less than 5 centimeters in measurement, then that would fall under too little fluid for that baby. That would be oligohydramnios. The vertical pocket, if it's anything under 1 centimeter, would be considered that. And this will generally signify to us, okay, something is not right. Baby is not thriving in there. We could have some fetal factors, so urinary tract abnormality, or some maternal factors. If mom has hypertension, if we have PROM or PROM, or placental insufficiency, which we will talk about all of these, but just know that they are contributors to oligohydramnios. Then on the flip side, we can have too much fluid. So polyhydramnios is when we have a AFI of greater than 24 centimeters. We're not going to do the largest vertical pocket here because we could have a pocket that's small in one spot that wouldn't add up to make that 24. So just notice that with the polyhydramnios, we're not going to use the single largest vertical pocket. Now with polyhydramnios, too much fluid being produced could be because of the fetal nervous system. Remember, in the 3rd trimester, that fetus is the main producer of amniotic fluid. And so if we have a GI tract or a cardiac abnormality, we could have way too much fluid being sent out instead of being processed. And then the maternal side of it, if mom has preeclampsia or diabetes or her own cardiac disease, she could be too much fluid to be produced. Now, AFI or AFB is a part of the next topic we're going to talk about, which is the biophysical profile. So biophysical profile is a really good test to check for fetal hypoxia or a lack of oxygen getting to the baby. So if we are doing a biophysical profile, it's usually for mom not feeling kicks, or no movement from the baby, or mom's having some abdominal pain, or she's past due dates. If she's getting closer to her due date, so she's 39 weeks, they're going to be doing them quite frequently. There are 5 parameters for the biophysical profile, 4 of which we look at. So the one we don't really look at would be the non-stress test. So the non-stress test, they hook mom up to the fetal EKG, and they're watching for those heart accelerations, and they want to see 2 within 20 minutes. So that is on their side. For our side, we have 4 main categories that we're going to look at. The first one being the amniotic fluid index or volume, which we just covered in detail. At least one pocket that is greater than 1 centimeter across and 2 centimeters vertical, or a overall 4 pockets of greater than 5 centimeters added together. The next one is the fetal breathing. We want to see 1 episode lasting 30 seconds or longer in a 30-minute time frame. Then for fetal movement, we have 3 separate movements, and they need to be gross movements. So flexing of the spine, rolling over, big movements of the core of the fetus, not arms and limbs. The next one focuses on arms and limbs, fetal tone. This is 1 episode of flexion and extension in 30 minutes. So opening and closing the hand, reaching out and pulling back in the arm, kicking mom with a leg, whatever it may be, we need that flexion and extension, extending and pulling in, opening and closing. For biophysical profile, we score on a score of 8, not including the non-stress test. And each one of our parameters gets a 0 or a 2. There is no such thing as a 1, a 1.5, a 1.75. If you do not get 3 separate episodes of gross movement, it is a 0. If you get 2 gross movements, it's a 0. If you get 1 breathing episode of only 15 seconds or 25 seconds, that is considered a 0. They do not get a 1.5 for doing half of the job. So a 0 or a 1, and then we watch the baby depending on how they scored. So if we had a AFI of 10, we had 1 episode of breathing lasting 40 seconds. We had 4 episodes of gross movement and 1 episode of flexion extension. That is a score of 8 overall. 2 for AFB, 2 for breathing, 2 for movement, 2 for tone. Now say that we did another one right after and we had breathing, we had movement, we had tone, but our AFI is 4. This would be a score of 6 because we got a 0 on AFI. All right, so that is the biophysical profile. That is what we're looking for in the 3rd trimester, what we need to include in our protocols. Remember, we're going to be using a curvilinear, the highest frequency probe that we can use without losing our image, not having our resolution. That's the word I was looking for. Having our resolution good, we want to have the highest frequency with our depth. We are going to next look at pathology in pregnancy, and we're going to try and break that down by systems. So check out the next video for that.